are going to be discussing quality improvement in the PMTCT program. I will be a facilitator for today. My name is Chansa James. So we have a very loaded and very exciting session, like I had mentioned. And but before I get into the details of that, allow me to just recognize the presence of Dr. Phiri, who is here with me and who's going to be one of our didactic presenters. Dr. Phiri, you're welcome.
Thank you, and good afternoon, network.
Okay, so like I had mentioned, we are going to have a very exciting session today, and it's going to be a tad bit different from what we usually have.
We learn everything health related.
The hub is muted. Unmute the hub. Okay.
Sorry.
Thanks.
Okay. So like I was saying, we are going to have a very exciting session today, and it's going to be a bit different from what we usually experience during an echo session. Just a quick run through for our session today. We are going to begin with a reflective case, which will be given by Mary Jere, our healthcare worker from Kahari Rural Health Center. And what is so special about this case is that it will actually give a testimony from a mom who's actually been a recipient of care for the PMTCT program. We will then move on to a didactic presentation, which will be clinical in nature and will be given by Dr. Phiri. And we are going to have a collaborative discussion after that for a few minutes. Thereafter, we are going to have a QI presentation, which will be given by Mary Jere once more. And after that, we are going to have another discussion before we move on to another QI didactic presentation, which will be given by Dr. Clemens. So I would just like also to thank our panel of experts that will be joining us here today. I think I did see Dr. Wood in the participant list. But we are going to have Dr. Priscilla Mulenga, who's going to be our expert during the clinical didactic presentation. And we have Dominic Sashi, Harrison Kambambi, Jacob Mhone, Rabecca Banda, and Dr. Brian Wood, who are going to assist us with the QI didactic presentation discussion. So before we get into the program, allow me to just remind the network to ensure that your mics are on mute as we progress with the session, and IT will be periodically sharing the link, the registration link in the chat. And so if you are logged in as a group, we do actually encourage that each and every one of you does actually sign in. So without further ado, I will hand over to Ms. Mary Jere to give us our reflective case for today. Ms. Mary, would you like us to share the slides from here, or are you going to share them from your end?
You can share them for me.
All right.
Good afternoon. My name is Maria from Kahari Health Center with our reflective case scenario. Next slide. Next slide, please.
So we've already gone to the next slide. Are you able to see it now?
No, I can't see.
Okay.
Okay, thank you. So our reflective case, we have a young woman. She's NK, she's age 22. She lives with the grandmother and delivered a bouncy health baby boy. I can't see.
Keeps loading. Keeps loading. Can't even do the name. Apologies for that. We seem to be having some technical issues. I don't know if you can see the slides now, Mary.
I still can't see them.
Okay, we'll get IT to help us. But if you do get to see them, you can just proceed with the presentation. But we
Okay, I can see them now.
All right, please continue.
So she had a healthy bounce male baby as a first delivery on the 17th of December 2021. She had 3 ANC visits, and in this visit she was tested for HIV with a negative test being the last one during labor. She stayed fair and well when the child was 1 year and could come to the clinic complaining of fever, headache, and general body pains. She was given Coartem for malaria and retested and was found negative. In June 2022, she brought her 18-month-old baby for routine under 5 clinic. It was during this child clinic that she was retested and was found HIV positive. The baby too was tested on the same day and was confirmed HIV positive. So both mother and child were treated on ART. Next slide. Next slide. So this is a story. I was in the process of winning my 18-month-old baby when I was told I was HIV positive. This broke my heart. But when news that my baby too was positive was told to me, I was so devastated. Both my baby and I were put on treatment. The drugs affected my child because the drug would make him vomit. Both the baby and I discontinued the drugs. With counseling, home visitation, and personalized care, I restarted treatment. I'm now able to take my drugs properly. I am also able to give my child his drugs. He is now tolerating the drugs and is well. However, life for me has never been the same. I have not been able to disclose my HIV status and that of the baby to the father of my child. It has been difficult. Only my grandmother knows. My child is now 2 years, 6 months, but how will I ever tell him that he's HIV positive?
Thank you so much, Mary, for that presentation. I think NK's story is not very unfamiliar, especially for those that are working in the PMTCT space. I think this is a story that we usually do get to meet. As we progress with the session, I would like for the network to just ponder on this question. We are not going to discuss it, but I would like us to think about what could have been done better to save this baby from actually getting HIV infected. So as we go ahead with the session, please ponder upon this question, and then maybe we could talk about it at a later session. So from here, I will hand over to Dr. Chimika, who's going to give us our clinical didactic presentation entitled PMTCT Program Context. This one. Chimika, the floor is yours.
Thank you, Chair, and good afternoon once more, network. And thanks, Maria. So part of the reflection on the case that Maria shared will be what we're going to discuss. So basically, I'm going to share with you in terms of the program perspective regarding HIV retesting and the PMTCT program. So this will be the program outline. I'll look at backgrounds and then zero in terms of Ministry of Health in Zambia recommendation in terms of retesting, and also just to discuss some retesting coverage across the 10 provinces, and then we'll also look at the interventions. So we have a question.
Okay. So our first poll question reads, which of the following is true? A, the goal of PMTCT program is to eradicate MTCT of HIV. B, in 2022, the PMTCT program in Zambia did not record, did not record any incidental HIV infection in pregnant and breastfeeding women. And C, mothers dropping off ART during breastfeeding contributed approximately 13% of breakthrough HIV infections among the infants in 2022. So dear network, please feel free to poll in. We have about 188 participants on the call, and so we would encourage all of you to actually poll in. Okay, we're still under 50%. We'll give it a few more seconds before we close the poll. Remember, there are no wrong answers in adult education. We are all here just to learn. So please feel free to actually poll in. Okay, we already have one answer that seems to be a favorite. And we're just slightly over 50%. Just a few more seconds to give others to poll in as well. Okay, we are going to be closing the poll, and I'll end the poll right now and share the results. Okay, so from the first poll, about 86% of the network that polled in actually think the answer is A, which is the goal of PMTCT program is to eradicate MTCT of HIV. I'm sure Dr. Phiri will shed more light on this one as we proceed. Dr. Phiri.
Thank you, and thank you, network. Clearly there, the polling shows that democracy does not always go in favor of the majority. Yes. So it's about the terminologies here. So actually the PMTCT program goal is to eliminate mother-to-child transmission. Now we are dealing with 2 diseases, and soon we're still working on the 3rd one. We'll have the triple MTCT. So basically the goal is to eliminate and not to eradicate. There are 2 different terms there. So when that's why I'm saying the majority
doesn't always.
Yes. So let's analyze these terms critically. So it's not really, for now, it's not to eradicate, because in the public health, eradication and elimination, there are 2 different terms. But for the PMTCT program, the goal is to eliminate mother-to-child transmission of both HIV and syphilis. And soon, as I mentioned earlier on, we'll add on viral hepatitis B. So it will be 3 diseases that the program wants to eliminate. And to that effect, we have targets. So just to remind the network that the HIV infection that we see in pediatric population is mainly through mother-to-child transmission. And this actually accounts for more than 95%, meaning that the horizontal transmission is very minimal, it's around less than 5%. So this actually calls for interventions to halt the transmission, would reduce the transmission via the common route, which accounts for more than 95%, which is mother-to-child transmission. So in 2022, when we looked at the program performance review, we realized that as a program, we have continued seeing breakthrough infections, which means we still see babies born from mothers who are HIV infected, or even those that even pregnancy tested HIV negative. On the way, we still get some babies getting HIV infected by the time they reach 24 months of age. So as a program, what we noted in 2022 was that we still have the incident infections of pregnant and breastfeeding women. This means that there are these women that initially tested HIV negative, probably during pregnancy or early postnatally, but on the way, they seroconvert. So these are incident infections. And then we have those mothers that are receiving and are not receiving ARVs or are not on treatment, and yet they were diagnosed HIV infected. And then we have the mothers that were rightly put on treatment, but on the way they drop off treatment. So these three categories of women, we saw that they contributed a significant percentage of breakthrough infections to the newborns. Next. Okay, so just to put it into terms of actual data. So the three sources that I earlier alluded to accounted for 70% of the breakthrough infections that we saw in the year 2022, meaning that out of the total number of babies that got the HIV infection from the mothers, of course, through PMTCT vertical route, 70% of them actually got the infections from from mothers that had instant infections, and then the mothers that were not receiving ART, and the mothers that dropped off from ART. So in terms of the specific contributions, again, here we see that the babies that got infected from the mothers that had instant infections accounted for approximately 35%, which is very significant. And if you look at this, 10% of these mothers are those ones that seroconverted during pregnancy, and 25% are those mothers that seroconverted postnatal. So you see that quite a good percentage of mothers are those that tested HIV negative during pregnancy, and then postnatally they seroconverted. And then, as I mentioned earlier on, we still saw 22% from those mothers that we diagnosed with HIV, but for some reasons they were not started on ART, and also further those mothers that were on treatment, but on the way they dropped off from care. So they accounted for 13%. All right, so we can now have a second question.
Okay, so for our second poll question, it reads, regarding HIV testing services in Zambia, which one of the following is not true? Regarding HIV testing services in Zambia, which of the following is not true? So A, the PMTCT targets to achieve 95% HIV testing coverage for pregnant women by 2026. B, HIV negative pregnant and breastfeeding women should be retested every 3 months. C, male partner involvement is not one of the interventions to improve retesting coverage in pregnant and breastfeeding women who are HIV negative. So dear network, you can begin to poll in. I will just go through the options once more for those that indicated. So A, the PMTCT program targets to achieve 95% HIV testing coverage for pregnant women by 2026. B, HIV negative pregnant and breastfeeding women should be retested every 3 months. And C, male partner involvement is not one of the interventions to improve retesting coverage in pregnant and breastfeeding women who are HIV negative. So dear network, please feel free to poll in. We are close to 50%, but we would like for everyone to actually poll in. Also, as we're polling in, I would just like to remind the network that the registration link has been shared in the chat. So we do encourage that each and every one of you do actually register. It is important for the sustenance of the program, and also you could actually claim a certificate to for your CPD and CME points. So we'll be ending the poll in a few seconds, and we'll share the results. Okay, so we have about 60% of the network that has polled in. I will end the poll here and share the results. So for this question, Dr. Phiri, the network feels C is the answer, which is male partner involvement is not one of the interventions to improve retesting coverage in pregnant and breastfeeding women who are HIV negative. Remember, this question was talking about which one of the options was not true. So I'm sure Dr. Phiri will shed more light.
Thank you, Chair. And indeed, this time around, it appears democracy has favored the majority. Yeah, so as a program, we have what we call the impact indicators and as well as process indicators. So one of the process indicators speaks to the coverage of HIV testing for pregnant and breastfeeding women. So in this case, as a program, our target is to achieve a 95% HIV testing for the pregnant women by year 2026, and this is actually outlined in our new the 2021 to 2026 PMTCT guidance, yes. And then furthermore, looking at what happened in the previous slide that was shared in terms of looking at high incident infection, this calls for concerted effort to ensure that we increase the retesting of those pregnant and breastfeeding women that initially test HIV negative. Okay, so as a program, as HIV program, as we all are aware that HIV services testing is part of the comprehensive PMTCT package that we're supposed to offer to every eligible pregnant and breastfeeding women. And all the pregnant women or breastfeeding women that test HIV negative, on first occasion, we need to plan to ensure that we retest them every 3 months. This is an effort to ensure that we capture or identify those that seroconvert early and put them on treatment as part of the intervention for PMTCT, and as well as to take care of the exposed baby. First of all, testing if baby is negative, then we put the baby on prophylaxis. So I thought I could share with the team network in terms of the performance of the 10 provinces across Zambia. And you can see this speaks to the performance in the first quarter of this year in terms of retesting. So the blue bars indicate the eligible pregnant and breastfeeding women that were supposed to be retested, but the orange or the amber bar, you can see how we performed. So wherever you are listening from within Zambia, you can actually look at your province and see how you performed, right? So next slide. This actually puts it in better so that you can see the figures. These figures are in terms of percentage. And you can see at the far end there, we have the average national. So we're at, as a nation, we're at 10% in terms of retesting based on our program data, with Eastern Province leading there, but even then it's just 18%, right? So again, this is how we've been performing between January and April, okay? So this is somehow in agreement with what we're seeing in the picture of having contributed, the incident infection have been contributed to high numbers of breakthrough infections. And we can only improve here if we increase the retesting coverage. So this is worrying, and we'll see what some of the interventions that we put in place to ensure we increase this coverage next. So what are some of the interventions that the program has put in place as a ministry? I'm sure many of you are aware that now we have introduced a health booklet. Soon, I think it should be in circulation. So this one covers both for the baby and the mother, and on the component of the mother, actually it's got the retesting schedules for those that are HIV negative. We're hoping that this too will help us remind providers or healthcare workers to document and see and capture those women that circumvent and We have also noted that there's low male partner involvement. Many times the pregnant women or the mothers, when they come through, they want to, first of all, consult their partners. So we feel that, and this has actually shown that it actually improves, especially the provision of certain services to pregnant and breastfeeding women where partners are involved, not just testing, but we want to encourage facilities to promote male partner involvement in this area. And then also, we are working out in terms of the having a structured appointment system. This time around, for those that test the women that are HIV negative, the way we do it, so the approach will be pretty similar to the way we do it for those recipients of care that are accessing ART services, where we know how many are supposed to come on a particular day, a particular month. So similarly, the same approach will be encouraged to be used now, targeting the pregnant and breastfeeding women that test HIV negative, so that we can track those that miss appointment and make sure that we find them and offer the testing. And we also want to ensure that we interrogate our data just to see how we are performing as reflected in the provinces. If we do these regular performance or data review meetings, we should be able to identify that we are not doing well in this area in terms of retesting and put in measures so that we improve the coverage as a facility district or as a province. And one of the reasons that came through, I think, was the issue about rationing of the HIV testing commodities. But as a ministry, I think measures have been put in place to ensure that, with of course, goodwill from partners, to ensure that HIV testing commodities security is prioritized. So moving forward, you'll be seeing that we have enough test kits. There will be no need to ration to say we are keeping these test kits for our general population, but we want to make sure that in MCH, all those that are eligible for retesting, they should be offered their services. And indeed, continuous quality improvement projects, just like it is applied to other program areas, we encourage facilities to prioritize some activities around PMTCT to ensure that CQI projects are implemented. So these are some of the many activities or interventions that have been put in place, and we encourage provinces, district facilities to ensure that these are actually applied. Thank you. It was a short presentation. Yes. Thank you, Chair.
Thank you very much, Dr. Phiri, for that presentation. And I think a lot of important issues have been highlighted. And some of these do actually speak to the question that we encountered when we just started our session. What other things could have been done to improve or better yet, to ensure that NK's baby was not infected? So we do have a number of items in the chat. But before we maybe get to the questions, if Dr. Priscilla Mulenga is on the call, under 3 minutes, would you like to give some comments towards the presentation? Dr. Mulenga. Okay, I don't think Dr. Mulenga is on the call, but once she joins us, we will actually give her a chance to give some comments. So we'll comb through the chat just to see some of the questions that have been asked. But if somebody would like to ask a question right now, kindly just raise your hand and we'll give you a chance to speak. Is there anyone who would like to ask a question or make a comment towards the presentation, or maybe towards the case that we actually started with? Okay, so most of the items in the chat are relating to the poll questions, but we do actually have one. So Chilufya Mola would like to ask a question or make a comment. Kindly unmute and give your comment or ask your question.
Good afternoon, Dr. Chansa, and good afternoon to the presenter. Let me start by saying that was a very wonderful presentation. And you could also see that from the responses of the people on the network, there's very good understanding of PMTCT management from the board. I have a question, however, on the data that was presented. And I do see that indeed Zambia has a challenge when it comes to retest. And the way the data was presented was in a way that anchor retests, labor and delivery, postnatal were grouped together for quality improvements, project SEC, and also seeing that you've also indicated that CQIs is one way that you would like those implementing quality improvement projects take up as a way to deal with this problem. Are you able to highlight for us which among those three is very hit? And then that most likely will give a guide to those that are going down to do facility reviews, as you earlier indicated. Thank you.
Thank you very much for that question, Chilufya. So, Dr. Phiri.
Thank you, Chilufya, for that important question. Yeah, so I don't have the breakdown in terms of the performance and in terms of the three categories during pregnancy, labor and delivery, and postnatal. But that can be, that information can be provided. I could ask the M&E team to break it down. But what I wanted is just to show the network that we have a problem here. However, if you looked at the breakthrough infection that we had in 2022, compared to the contributions, the 35% came from stent infections that were actually recorded, both during pregnancy and postnatal. But you saw that postnatal it was 25%, meaning that we are having more women circumventing postnatal. So this area, if presumably we were doing very well, we could have been capturing these women early and put them on treatment and intervene for the newborn. So I could make an intelligent guess that probably we are may not be doing very well, especially the postnatal period, because if you look at it, it's actually a longer period, and most of these women come through. And even anecdotally, when we visit sites postnatally, we are struggling to retest these women. But as you requested, I think it would be nice to pack it with data. And this is one of the issues that we'll ask the M&E team to provide.
Okay, thank you very much for that response, Dr. Phiri. Chilufya, I hope your question has been answered. So there's Severino who would like to ask a question or make a comment. So just under 1 minute, kindly unmute and make your comment or ask your question. Severino.
Thank you very much, Doc, for this opportunity. I would like to appreciate the case presentation. I think that's very good, well done. Just a quick one with respect to our client who said she has clearly told us that she has not disclosed to the father of the child that she's on treatment, which means even the child probably, the father doesn't know that the child is also on treatment. I would like to find out if this lady is staying with the father of this child or not, because I'm worried if they are staying together with the father of the child and the father doesn't know that she's on treatment. I'm wondering how free she is to take these medications, and I think issues of adherence to herself and to the child might be a problem. If I told the father of the child stays together with this lady and the child, I think it's very important to see how we can loop in this father to this treatment as well, so that the mother and the child can be taking the drugs freely. That was just my comment. It really is not a question that begs a response, but that's just my observation. Thank you.
Thank you very much, Severino. And I'm sure Mary, Mary who presented that case has taken note. Those are some very important points that you've actually raised. I'll give a chance to Innocent to make a comment, and then we'll read some questions from the chat before we move on to the next item. So Innocent, kindly unmute and just ask your question or give your comment.
Okay, the host is not allowing me to unmute. Are you getting me?
Yes, we can get you.
Okay, thank you so much. I think my question has been covered because it was going through the case presentation as well. I'm worried, are there any other type of indexing contact that they have done to make sure that they reach this man? Because if it's true, the woman might be hiding, who knows, maybe the one who's already on treatment. So it's important as well that we look for the man so that at least the status is disclosed, either direct or indirect.
Thank you very much, Innocent. Indeed, that is actually very true. And if we do have a few minutes at the end of the session, I think we could allow Mary to give or shed a bit more light on that case. So since this was a similar question or comment as the previous one, Nakambala UNC, under 1 minute, kindly ask your question or make your comment.
So thank you very much, Chair. This is Chimika. I wanted just to add on what Dr. Phiri indicated with regards to the earlier question which was asked. So in our DHIS2, the retests for ANC, labor and delivery, and also PNC are combined. So at a higher level, we are able to know which one are we having, where we're not doing fine. But like the data Dr. Phiri mentioned, you would see that almost all the provinces we are less than 15%. So I think it also shows that in all the three service delivery points, we are doing badly, because if we combine all of them, we are less than even 20%. So I'll just add on what Dr. Phiri mentioned. Thank you very much.
Thank you very much, Chimika. There is a question in the chat from Edwin Musachi.
From Central,
okay. MOH. So actually, Chimika is from Central, from MOH, and I think his addition is very important to this discussion. There is a question from Edwin Musachi. Is the dual HIV syphilis test kit still suspended? I saw Dr. Priscilla in the participant list. Dr. Priscilla, would you like to give a comment to this question? Dr. Priscilla Mulenga. Okay. Okay. Dr. Phiri, would you like to respond to this question?
Well, I think Dr. Priscilla should be in a better position to guide. Yeah.
Okay. Yeah. So we'll bank this question, and we'll give a chance to Dr. Mulenga once she's on the call to give us this response. So we'll move on to the next item of our agenda today, and this will be the QI presentation on PMTCT, which will be given by Mary Jere. I will be sharing the slides from here, unless you would like to share them from that side, Mary?
No, yeah, you can share them from.
All right. Okay, I hope you can see the slides.
Yes, I can see.
Okay, the floor is yours.
Okay, good afternoon. This is Maria once again.
sharing this one. Sorry, let me just reshare that. This one. No. Which one is it? This one. This one. Okay, sorry for that. I think I shared a wrong presentation. I think this should be the correct one. Please proceed.
Okay, good afternoon once again. This is Maria Jere once more. I'm from Kahari Health Center in Western Province in Kambambi District. Next slide. Our project title is Increasing HIV Testing Uptake in Breastfeeding Mothers at Kahari Rural Health Center. It started on 31st January and is running up to 28 February 2024. We're in our implementation stage. Next slide. Our background. Kahari Rural Health Center is located in Kambambi District. That's about 7 kilometers from the Saka-Mungu Road, with a head count of 12,229, with expected live birth of 623. The community is mainly nomadic due to farming activities. The facility has 9 neighborhood health committees with several entry points, including MCH. And next slide. Performance statements. Standard expected performance, at least 95% of HIV negative breastfeeding mothers should be retested for HIV. Actual performance, only 35% of HIV negative breastfeeding mothers were retested for HIV at Kahari Rural Health Center. Our desired performance, at least 95% of HIV negative breastfeeding mothers should be retested for HIV at the facility. Our performance gap was 60%. Performance gap statement, 60% of breastfeeding mothers are not retested for HIV at Kahari Rural Health Center. Next slide. Performance, our main performance indicator. So for the numerator, number of HIV negative breastfeeding mothers retested for HIV at Kahari Rural Health Center by MCH staff. Our denominator, total number of HIV negative breastfeeding mothers due for HIV retesting at the Kahari Rural Health Center by MCH staff. Next slide. Justification. So Kahari Rural Health Center in 2022 recorded 0.9 seroconversion in previously HIV negative breastfeeding mothers. Unfortunately, these mothers passed on the infection to their infants. So on that analysis, we found that only 35% of negative women were being retested in the last quarter of 2022, instead of the national standard of 95. So it was against this background that we decided to do a QI project with the aim to eliminate mother-to-child transmission of HIV. Next slide. So the facility used the fishbone to analyze our root causes and under the 6 performance factors. So under the 6 performance factors, the highlighted ones are the final root causes. So under knowledge and skills, we had the orientation not planned for MCH staff on correct data entry. Under environment and tools, we had no provision for maternal HIV results on the under 5 card. Under job description, we had 3. The first one was the in-charge does not know that she's supposed to supervise or to counter-check the officer's activity after the end of the shift. We had under job description, there's no IEC schedule in place. The other one, the in-charge did not identify SMARCs, which are self-motherhood action groups, to be oriented and certified in HIV testing. Under organizational structure support, we had lack of maintenance scheduled by DHO. Under performance and feedback, we had no data review meetings scheduled in place. And under motivation and incentives, we didn't have anything. Next slide. So these are the root causes listed. Next slide. So the interventions and change ideas, attached a card for antenatal HIV testing on under 5 card for easy identification for those due for retest. SMARC and adolescent mental identified and recommended for training to increase and carry out community and facility HIV retesting. Scheduled on-site orientation of all staffs on documentation of results in the MCH register. We wrote to the stakeholders for a meeting for sensitization and resources and support. We had an MCH focal person who was tasked to assign a staff every week to give IEC to bridge knowledge gaps in breastfeeding mothers. Next slide. So our performance tracking, so the interventions, the outcomes, and what we observed. So on the first one, when we have ongoing attachment of a card for antenatal HIV testing on the under 5 card by MCH staffs every under 5 clinic. So those who don't have cards, they have been attached. So what the outcome is that all staffs are now documenting results on the card, and breastfeeding mothers now have valid documented results and a scheduled next appointment schedule. And then a SMAG and adolescent men that were identified and recommended for testing. So one SMAG, one adolescent men that were tested, were trained and certified for HIV testing. So all eligible mothers are being retested in the MCH and community. We scheduled on-site orientation for all staff on documentation of test results in MCH registers. So all staffs are now oriented, and then we are seeing that HIV results have been appropriately documented in the registers. So we wrote to our, the other one, we wrote to our stakeholders for a meeting, which was held on the 13th of February with our partners, our sub-chiefs, the DHO staffs and the others. So we had support in terms of a motorbike for outreaches. On the 5th one, the MCH focal person was tasked to assign someone to give IC every week. So we have a schedule and timetable in place, and now we have a staff giving IC every Wednesday and Friday. Next slide. So that's our results and outcomes. In January, when we were just starting the project, we were 35, and then in February we rose to 40. This is due to attaching the maternal HIV testing on the under 5 card and the stakeholder meeting. So from February to April, we were doing very great, but in May, unfortunately, we dropped to 61. This is because the facility had run out of some vaccines, so mothers were not coming for retesting, but were going to other facilities. Next slide. So what we learned, our game changer for us really was when we started attaching the maternal HIV retesting on the under 5, we're able to know who's due, who's been tested, and those not documented were being documented. So this was what we learned. And what we love to recommend as a facility is that we feel that there's a need to revise the under 5 card so that it's standardized to include maternal retesting results and appointment days, so that we know if someone is due in 3 months, at least if the date is there, wherever they go, they're able to be retested. Next slide. So our data forces, we had the 0-24 months register, our postnatal register, our labor and delivery register, and the HIV testing custody register. We'd love as a facility to acknowledge our in charge, the DHO, ICAP, DAP, and the Western Province Health Office, and JAPIGO. So our question is, what other ideas can we as Kahari Rural Health Center QI team consider for HIV negative breastfeeding mothers to ensure that no baby seroconverts?
Hey, thank you very much, Mary, for that presentation and for the work that was done on this QI project using the QI principles. I will just repeat the question for the network. What other change ideas can we, and this is Kahari Rural Health Center QI team, consider for HIV negative breastfeeding mothers to ensure no baby seroconverts? So we are going to open up the discussion, but before we get to the questions, perhaps one of the experts from the QI team would like to give a comment as we wait for questions. Mr. Dominic Sashi, would you like to give a comment?
Thank you so very much. First and foremost, I just want to commend the presenter, session. Sure everyone was able to follow the story from the way it was done in terms of the organizational context up to the presentation of this is commendable. I know that one of the things that we really want to dive in is the use of data. And remember that if we cannot use data, it's very difficult for us.
Mr. Sashi.
Are you able to hear me?
Sorry to cut you short. Your network is not very clear, so we can't actually get you. Perhaps maybe you could change your location and then give us the comment. The network is really bad. Mr. Sashi, did you get me? Okay, it appears we've lost him. We've got some items in the chat. Perhaps we can begin with those and maybe, okay, there's Nakambala Urban Health Center as a hand raised. Kindly unmute and give your comment.
Thank you very much, Chimika again here. First, I'll start on the part of the QI. So far, so good. Maybe the team need to just fine-tune one or two issues. If you go to the fishbone, when you check on the tools and environment versus skills and knowledge, they seem to have swapped the issues because issues pertaining to registers, they place them under skills and knowledge, which are tools. While also issues of people not knowing what to do, they place them under tools and knowledge instead of, or tools and environment instead of skills. The other aspect, before I go to what they can improve on, I'm just trying to give them also a feedback. The other aspect on the presentation, they itemize the root causes. But when it comes to the intervention, there was no clear demonstration as regards to the root causes they itemized, which intervention were there for. So it's like we have root causes on one side and intervention. So there was no link to show for those interventions, they were meant to cure which root causes. Then on the question raised as an, what else can they do? I want to just encourage Kahari through the PHO to ensure that they collect the new register we have worked on, which is the immunization register. So it has aspects with regards to the feeding option, the status of the baby, which also now help the facility to identify which mothers are due to be tested at a particular time after taking into account the feeding option of these children, especially those who are these children are not exposed, so that we test these mothers. Thank you, Chair.
Thank you very much. Thank you very much, Chimika, and I'm sure Mary has taken note of those comments. So before we go to the other questions, Edwin Sashi, your question is very much noted. Dr. Priscilla will give us a better answer to this question, and so we haven't ignored your question. So we'll get back to it with Dr. Mulenga. I will read out some other questions from the chat. We have a lot of congratulations from the chat to the important work that was done by Kahari. Okay, Twambo has a raised hand. Kindly unmute and just give your question.
Thank you so much, Doc, and good afternoon to everyone on the network. I just wanted to add on the question why they are asking about the best practices which can help them improve also on their performance. Considering that us as Chilenje sub-district, we are also doing the same project and looking at what has helped us. It's the reminders. We are calling the mothers that are due every month for testing, and this has really improved our monthly coverage. So if they can manage, if they have clients that have valid phone numbers or using the same SMAG system that they've employed, they can also see a better change in their performance. Thank you so much. I submit.
Thank you very much, Twambo. And I'm sure those points have been noted as well. There is a question from Keegan that reads, what intervention has the facility put in place to improve male involvement in effective implementation of PMTCT at facility level? I think this question is in reference to the case that was presented at the beginning. And like I had mentioned, I think if we have some time at the end of the presentations, we could address some of these issues. But just to stimulate the network, are there any other added interventions that we think Kahari could have put in place to improve their outcome? This is a general question to the network. Please feel free to just unmute and give a comment. Okay, I think we are mic shy. Mr. Sashi, or anybody from the QI experts, Mr. Harrison Kambambi or Mr. Jacob Mhone, would you like to give a comment? Okay, Dr. Brian Wood, I think I saw Dr. Brian Wood. Would you like to give a comment towards the QI project that has been done by Kahari Health Center?
I'd be happy to offer a short comment. Thank you, Chair. I think it's an excellent model of assessing root causes and developing simple interventions that really seem to make a big difference when you look at the numbers and the change. So I commend the team and thank Maria for sharing the work. One thing that crossed my mind, another option to gather input would be to conduct focus groups or listening sessions with breastfeeding mothers themselves to get their perspective and input on barriers. Is the main issue a lack of awareness and education about the importance of testing? Is it that after baby is delivered, they are so focused on basic needs for their family and their baby and the lack of transportation or other issues? Is it a need for reminders, as was brought up? I thought that was an excellent point. Is it stigma and fear of testing and fear of what happens if a result is positive, fear of intimate partner violence, as has been mentioned? So that's could be another opportunity to gather perspective and input and help develop interventions and something that could be considered. So I'll offer that for thought, but again, I commend the team and appreciate all the sharing and discussion. Thank you, Chair.
Thank you very much, Dr. Wood. I think very important comments coming from Dr. Wood. The major stakeholder really does need to be engaged to actually move this agenda. So we will move on to our next item on the agenda, unless there's anybody who would like to make a quick comment, last quick comment towards the QI project. Okay.
Thank you so much, moderator.
Yes,
Jacob Mhone here. Okay, just a few comments on the presentation on the QI from Kahari. That was a good presentation, and we appreciate the good works that are taking place in Kahari. But just a few observations on the presentation that they made. I think some of them have been highlighted by my colleagues. So I would advise the team to relook at the manner in which they did present their results. They did use a bar graph, which was able to show us the cumulative numbers and the progress that they are making towards the attainment of their target. But looking at the way their results are being presented, I think it will be very clear and easier to understand if the team can use a line graph as opposed to a bar graph which they used, because it will be very, very clear to see the progress that they are making. Then another positive that I noted on that one, they were able to indicate the change ideas that they were implementing in a particular month. In short, those annotations that they included there were a positive for me. Then for those areas of improvement that the network has shared with the provincial team, I think we've taken note of this. We should be able to see how we can work around this. This is the issue of the accusation of the new register, which a colleague of mine did talk about. We've also taken into account the pre-reminding aspect that was highlighted, as well as the bringing on board of the focused group discussions. Thank you, and over.
Thank you very much, Mr. Mhone, for those comments, very important comments. Mary, have your questions been answered? Or would you like more clarity?
No, they've been answered.
Thank you very much. So I'm sure you've taken note of some of the other change ideas that we can actually apply to actually improve the outcomes that we had. So we are going to be moving on to our next didactic presentation, which will be from the QI SAD and which will be given by Dr. Clemens. In the presentation, I would just like to remind the network once more to ensure that they actually register with the link that has been shared in the chat box. So, Dr. Clemens, the floor is yours.
Wonderful. Thank you so much. First of all, a warm welcome to all of you. I'm delighted to be here, and I'm grateful to the network to have invited me today. Today's focus is on giving you a few simple to use quality improvement tools that you can use. All of them do not require a computer. They're easy to use, but they're incredibly powerful in order to enhance a process that you want to improve. And in our case today is the focus on HIV testing of pregnant women. If you can go to the next slide, I wanted to start out with a quote that reads the following way: every system is perfectly designed to achieve exactly the results it achieves. I think it's important to notice that if we continue with the current process, we'll always get a certain performance, whether it's in rates, whether in outcome, whether it's in satisfaction. The only way we can change a system and therefore hopefully improve the results is by actually making a change to the system of care. And I wanted to start out there because I hope that the tools I will present to you will make a progress towards improving the care for the communities you serve across Zambia. Next slide, please. If you have any experience with the tools, I would encourage you to go into the chat and then add your experience with the various tools. Many of them may be familiar with some of you, but I would certainly encourage you to share your experiences, and hopefully, given the time today, we also can entertain some of the questions. The first one I want to reflect on is on the check sheets. Next slide, please. It's basically a simple tool. You can use pencil and paper to really track certain data points over time. It's whether used qualitatively or quantitatively. And it's really a very simple checklist of sorts that allow you to see where the certain steps that you wanted certain patients to go through actually went through. I want to start out with a very simple checklist. Next slide, please, which is basically a simple one. And I put in here, for instance, how satisfied was the patient with the waiting time today, and it can be certainly interchanged with other questions that seem pertinent to your clinic flow. So, and what you would do simply is you just write down, and what it can be done either through an interview, it can be done at the time the patient is on the way out, maybe it can be done during the waiting time, and you would simply note for each line here whether the patient was very satisfied. In this case, it's the satisfaction scale, mostly satisfied, neither satisfied or dissatisfied, so right in the middle, and then obviously go to very dissatisfied. I think what this tool very simply gives you is a qualitative assessment how well we are doing, and outcome is defined here as basically meeting the patient in terms of the waiting time and how satisfied they are. Next slide, please. This is more of a quantitative look in terms of how data. So you would basically count how many, for instance, HIV tests for pregnant women were tracked over time. So you'd start out, basically, you can have a roster of Monday, Tuesday, Wednesday, all the way through Friday, and just count them. And what this really helps you is to really have a better understanding about an idea of clinic flow. So basically, it gives you a good sense about what, in terms of staffing needs, in terms of numbers, HIV tests being need to be available. It also can address, for instance, seasonal changes and whatnot. And it will give you a good sense. And if you keep track of that for a couple of weeks, you probably realize very quickly, and you may get a good sense that in our clinic here, that the Wednesdays are the busiest day of the week, but often you need data to substantiate your point of view here. And then this very simple checklist certainly can help you. Next slide, please. You can also use this very simple checklist here for as a checklist in order to, for instance, come up with a process flow in your clinic. And then what you can do is just to track the patient over time. Did the patient sign in? Did the patient that's supposed to meet the counselor, did the patient meet the counselor? Was an HIV tested, offered to the patient? Was the results shared with the patient, and was a follow-up appointment made in case of an HIV positive test? So the idea here is that you can use this as part of a process flow and help you to determine over time. Let's say you do this for 20 patients, it will inform you, I think, very quickly about where potentially a process step is not working in the way you have designed it. If you go to the next slide, here are a couple of relevant examples that I wanted to share, and certainly would welcome any other examples that you have. Here, for instance, we can use this very simple checklist, or for instance, for the number of pregnant women tested per day, the reasons why women are not tested for HIV. For instance, you can come up with the most common reasons you can think of, and then interview the individual on the way out just to determine what is the main reason, to really have a data-rich decision based on the information that was gathered from the patient. And lastly, you can check whether all agreed steps for pregnant women were completed as designed. The next slide I wanted to show is our force field analysis. Some of you may be familiar with it. It's a staff interactive tool to gather, next slide please, about which forces are at play that will strengthen, however, also what will have a prohibitive factor. So basically, it would visually display, based on the input of staff and or patients, about what are the things that we reinforce the question at hand, or those that will negatively impact. What this will really allow, and you can use this, for instance, you can use a staff meeting for that purpose, to kind of brainstorm what are the barriers and what are the reinforcing factors that would allow you to reach a certain better performance level. The idea really is here behind this is to really focus on the barriers. How can we eliminate them, or at least reduce? But also on the positive side, how can we figure out how can we build a system that would benefit the patients we serve? If you go to the next slide, the process for that is fairly rather simple. Or you can gather a group of staff. You probably want to assign a facilitator just for those that are familiar with the process and can just guide the group through it. And then you first have to determine what is the question we want to answer, right? What quality improvement problem do you want to tackle that is of essence here? And then you simply put a piece of paper or a flip chart into two sides. One, you would say the driving forces that would allow you to reach that goal. And then you would, on this right side of it, would to say opposing forces, those that are barriers to for the question at hand. And then you would brainstorm the list with the staff. And at times it is very simple, often to come up with the opposing factors, so all those barriers. And I think I would force the group also to think about what would be the benefits and what can we do to really make it happen. And the idea really behind is that you can also prioritize the opposing and the drivers for this, and then really prioritize and then look at them from a lens of what changes can be made to the clinic. On the next slide, we want to show this a little bit on the visual side about how this would look like. Or so at the top of the sheet, you would write down what is our question. So in our case is to increase the HIV testing rate for pregnant women from 65 to 80% by the end of 2023. Or very targeted, very narrow. Hopefully, when you start, you want to ask for any clarifications. And then you want to identify the driving and opposing factors. And so you see here, for instance, the driving forces would be that HIV tests are stored where pregnant women are seen, so I don't have to go elsewhere. A daily log is generated who needs to be tested for HIV, so I can target a patient already in the area and conduct the HIV test. I'm pre-planning. And lastly, also peer support is critical to promote HIV testing around pregnant women. So those would be the driving forces. Those would help you to reach the goal as stated on the slide. And the opposing, and I think there could be certainly many, but in this case, we have here data are not available, who needs to be tested, the testing kits are not readily available, or the counselors are not available when pregnant women have their appointments. So I hope this tool, the force field analysis, will help you. Again, you don't need much. You can do it with a pencil and paper. The next tool I want to share with you is a run chart. And from Kahari team, we saw already a wonderful use of a run chart. Next slide. A run chart is basically a line chart over time, where a certain performance, whether it is absolute numbers, whether it's percentages, are tracked over time. It's very important that the same numerator denominator or percentage is being used. So you're comparing the same data over time. And what will allow you visually very quickly to determine what is where you are going with performance. It is actually one of the really hallmarks of quality improvement to use run charts. They're really important to use, and there are a couple of rules that we hopefully, if you're invited back, we can certainly talk a little bit more how can I quickly differentiate between a random data changes over time versus to have to know whether a certain data point, something actually statistically improved where it did not. When you go to the next slide, here's an example. So I used the Kahari slide and then turned it slightly in a different way and just those line graphs here and turned it into a run chart, where the blue line on the top is our goal. Where do we want to end up? And then the orange line is the actual performance over time. And what I like about here is it's called an annotated run chart. Is basically to say what steps have been taken to really make the difference here. So what PDSA cycle have been completed? And those are important because at times we forget 6 months before, what did we do? And that was very simple to document your tests over time. The next slide shows you very simple examples of those that are actually done on a piece of paper. Those are examples when I visited a clinic in Uganda. And again, what this again is a run chart. If I concentrate on the one on the right, it basically gives me the performance over time. It shows the, and it's annotated because it gives you the process steps or the PDSA cycle conducted in order to reach the goal. And on the bottom, which I really appreciate, is the actual numbers to see what is the numerator denominator, because the line that you see here is a percentage over time. The reason I wanted to show this slide is to give you a quick sense about how simple it can be used. And again, you can do this. In this case, it was posted in the waiting areas and for everybody to see, including staff and patients. The last slide I want to show you is not to go into details today before I open up to any questions you have and any thoughts and ideas. And hopefully we have some folks in the network today who can share with us their experiences. But this is a control chart. It's basically a run chart over time. And the difference is that you see those lines on the top, on the bottom, that would show you the upper and the lower control limits. It basically will tell you to differentiate between a random numbers that go a little bit up, a little bit down. That's the random factor. Or because if I go to work, let's say I take the bus to work and it will take me 35 minutes. And sometimes it takes me 45 minutes, sometimes it takes me 25 minutes. The process itself has not changed. Those outcomes, 25 minutes, 35 minutes, 40 minutes, are actually part of a randomness of how data are produced. But you can see here on this chart at some point that the data points are above the upper control limit. It means something happened, that the system actually changed to make the loop back to the very first quote from Paul Talton that says basically that the system was changed. And so this control chart, while I don't have the time today to go through all the details, would give you a good sense. So something happened in this data point worth exploring because the performance was not randomly improved, it actually improved for a very good reason. The next slide, I would leave you I want to probably bring the slides down before I want to thank everybody for listening, but I want to open up the floor to this network for any questions you have, any questions you have, and also if you have any experience with the tools we mentioned. And maybe I can put, if you can bring the slides down, thank you. Maybe we can go to the Kahari team first. Maria, sorry to put you on the spot, but it would be lovely to hear, how was it for you to do the run chart? And how was the experience with you? Do you find it helpful? And what were the takeaway messages from that? And sorry for putting you on the spot here.
Come again?
So it would be lovely to hear a little bit about your process to put the graph together that you had. And I would love to know a little bit from you how it was, how complicated it was, how simple it was, and what did you learn from looking at the data?
Okay, for the run chart myself, technology really failed me, so I had to ask the data personnel to do it for me. It was coming up with the percentage was a bit hard because we had to count from last quarter. So and the notations were a bit hard to put as well.
Thank you for sharing. I wanted to be sure that yes, we can certainly share those slides that were submitted to the chairs of the network. So we are happy to share the slides, and I hope that I can we'll make them available. Otherwise, you can always email one of us, and we're happy to share them with you. Any other questions, comments, anything you wanted to share?
So dear network, please feel free to ask any questions concerning the tools. I think you will agree with me that most of these tools are actually very simple and very user-friendly. But if you want to get any clarifications, Dr. Clemens is very much available to get your questions or your comments. So kindly just raise your hand and we'll give you a chance to speak.
If we are invited back, I'm happy to share more QI tools, and maybe we can share a few more. It's important to know what the tools are. Often you don't have to use all of them. but at time it's really important to know them. So when a question comes up, you know where to go. Isaac, you wanted to unmute. Do you have a question?
No.
Thank you, Isaac.
Thank you very much, Dr. Clemens. It seems you did a very good job. Seems there are no questions. I hope people actually understood. Oh, we've got one question from Mungomba. Dr. Mungomba, kindly unmute and give your comment or ask your question.
Thank you very much, Dr. Chansa. Thank you, Dr. Clement, for the presentation. Just on the control chart, in regard of QI, the presenter, our presenter, the one was making a presentation on maternal retesting. So we had those run charts and the way they were presented. Now, I want you to explain a bit on when the control chart is out of control, when you have data which is above the limit, the upper limit. So what interpretation can you give to that in line of QI? What can be the kind of intervention which can be put when we are out when we are out of control? I don't know if my question is quite clear. Thank you.
Wonderful. Now the question is pretty clear. So let me start off by saying that any data we collect are random, or because we don't know who is coming in on that day. Let's say in a very simple example would be waiting time was listed, so it's maybe not a very good example, but let's use waiting time. Or every day it takes a certain number. We don't know who patient come in, one staff may be out or whatnot. So there's a certain random factor. So if I would collect the data over time, it will never be the same score. If I look at virus suppression and HIV care, the virus suppression rate will go up a little bit, will go down from month to month, from day to day. And so that is because the quote I said earlier, every system is perfectly designed to achieve the results that is designed for. In other words, it will always give you a certain random number over time. So I go from virus suppression rate from 65 to 68, and it goes back to 61, and it goes maybe to 69. So that's a certain random number over time. The control chart is usually, for that you probably, unless you're very good in math, you probably need an Excel spreadsheet. Usually we use 3 standard deviations. So you would calculate the mean or the median. Over time, you need at least 12 data points. Ideally, you have 20 data points over time. And then you would calculate the median plus 3 standard deviations, and then the median minus 3 standard deviation. That means it tells you that as long as you fall between the upper and the lower control, all the data points, whether the virus suppression rate is 68, 69, 61, all those, as long as the data stay within, they're produced by the random factors. They are called the common cause variation. So then the question comes, if a data point is outside one of those, outside the control limits, it means something happened that is not randomized. Something happened that cannot be explained by the randomness. That could be, for instance, you introduce an intervention that is so successful that you're above the upper control limit. You can also have where all the staff are out, so then it would be below the lower control limit. I know this is probably a lot of information for some of you, but I wanted to respond to that. I'm happy to show this if you're invited back to the network to show you this. It's very simple to calculate. If you have Excel, you can do it. It is very simple to do, but it's very important not to, as in quality improvement, we call it, not to tamper with the system. In other words, not to overreact because your rate viral suppression rate range from 65 to 64%. It is very, very likely an artifact of random, of common cause variation. We're going to leave it here. I know this was probably too much information for some, but I wanted to respond to the question at hand.
Thank you very much, Dr. Clemens. Dr. Mungomba, I hope your question has been answered. Dr. Mungomba. Okay, it seems we've lost Dr. Mungomba.
I take his silence that he agrees with this, but no.
Okay, sure thing. Do we have any other questions before we wrap up the session? We have a comment from Melody in the chat that says, thanks for the presentation, Dr. Clemens. Question on the control chart, does it run parallel with the run chart, or it can be 2-in-1?
It is a 2-in-1 deal. You can look at them, and yes, it's 2-in-1. So you would do the run chart as you would usually do, and then you would draw in or let the Excel automatically calculate the upper control and the lower control limits. Any run chart can be converted.
Thank you very much, Dr. Clemens. So we will conclude this session for the QI2s. Again, I would just like to stress that, as you could see from the presentation, the tools are quite simple and very user-friendly. In case of the checklist, you could actually use them to identify where your gaps are and actually build your QI project from there. So I will allow Mr. Mhone or Mr. Dominic Sashi to just wrap up for the QI team. Any final words before we move on to Dr. Phiri to close out for us for the programmatic side? Mr. Mhone, any final words, or Mr. Dominic?
Okay, Mr. Mhone here.
Thank you. Please proceed.
Yeah, so on behalf of the Western Provincial team, we would like to say thank you to the network and all those that managed to log in today. A special thanks to all the contributions that have been made regarding on how we can improve the QI and ultimately improve the results in Kahari. Then, as I did highlight, we've taken note of all the positive feedback that has been given, and we've noted all the areas of improvement that we have to look at. Thank you.
Thank you very much, Mr. Mhone. So I will hand over to Dr. Phiri to just close out for us and perhaps respond to a question that Mr. Edwin had really insisted needed to be answered. Dr. Phiri.
So I thank you very much, Chair, and I think I want to thank the other presenters. Dr. Clemens, I think that was very educative. I think we have learned a lot from the Kahari presentation, and as a program, we want to encourage other facilities. Of course, we know, we heard from Challenge that they are also doing similar. So that actually gives us a lot of excitement in terms of learning that facilities have realized that there's a gap and putting in interventions. And one of them is to come up with the quality improvement projects. So our team, we have this battle to fight together in terms of to eliminate the mother-to-child transmission of HIV, syphilis. Soon we'll give a structured approach of the viral hepatitis B. So one good thing is that data has shown us where we are not doing very well. Clearly, these breakthrough infections, majority of them are coming from incident infection of the pregnant and breastfeeding mothers. So let's strengthen the retesting services. I think we have discussed some of the best practices here. And I'm glad to hear some of the facilities implementing them, including male partner involvement. So, and also for the input that Chimika is M1E officer from Ministry of Health. So they are the custodians of these data tools. So he was able to chip in. Thank you, Chimika. So there was a question concerning the suspension of the implementation of HIV service dual. Thanks for that question. I wish Dr. Mulenga could have responded. However, I think guidance was given to all the provinces during one of the scheduled meeting that we have, the bi-weekly, where our provinces are represented. So yes, the provinces are now implementing the program. If you have the test kits, please, if you've been implementing, go ahead and because these test kits they have got expiry. If you are not sure, please, you can reach out to the PNS MCH at the province, or indeed the provincial biomedical scientists, who should be able to give guidance, and we can work with them. Yeah, so I think that's what I could say. On the logistic part, in terms of the availability of the viral hepatitis B and syphilis test kits, I wish the people that are responsible could have given guidance, but it's something that we have noted across, and I think something is being done to address the gap. Thank you, Chair.
Thank you very much, Dr. Phiri, for those final remarks. So I know we've gone a little bit over time, but I will quickly just share the pause, reshare the pause that we had, and just see how we are faring now with the responses. So I'll launch the first poll. Okay, and it reads, which one of the following is true? A, the goal of PMTCT program is to eradicate MTCT of HIV. B, in 2022, the PMTCT program in Zambia did not record any incident HIV infection in pregnant and breastfeeding women. And C, mothers dropping off ART during breastfeeding contributed approximately 13% of breakthrough HIV infections among the infants in 2022. So dear network, please feel free. I know Dr. Phiri labored on this point. So we'll give it a few more seconds, and then we'll let Dr. Phiri just give a short comment with regards to the responses. So we've only got about 27% of the participants polling in. Please feel free. Okay, so I will close the poll at this point, even though we've had very few people to poll in, but perhaps we'll close it at this point and then just allow Dr. Phiri to give a short comment. So Dr. Phiri, about 60% of those that polled, I think the answer is C, but we still do have some people polling in as A. Brief comments.
Thank you, Chair. So the correct answer is C, and the majority actually got it right, 60%. So just to mention that the goal of PMTCT program is to eliminate and not to eradicate as it stands now. So let's be particular attention to those two terms. And indeed, as I earlier alluded, we saw quite a number of incident infection among pregnant and breastfeeding women in the previous year.
Thank you, Dr. Phiri. So I'll launch the second poll question as well. The question reads, regarding HIV testing services in Zambia, which of the following is not true? A, the PMTCT program targets to achieve 95% HIV testing coverage for pregnant women by 2026. B, HIV negative pregnant and breastfeeding women should be retested every 3 months. And C, male partner involvement is not one of the interventions to improve retesting coverage in pregnant and breastfeeding women who are HIV negative. So dear network, please feel free to poll in, and we'll give it a few seconds before Dr. Phiri can come in and give a final comment. Okay, we are getting better numbers on this poll as opposed to the first poll. I think people are shining away from the first poll. So just a few more seconds and then we'll close the poll and then briefly discuss the answer. Okay, so I'll end the poll here and hand over to Dr. Phiri to just give a final comment.
Yeah, so thank you. So again here, the correct answer is C, because we're asking which one is not true. So option A and B, the two are correct, so are true. So we said that our target is to have 95% of HIV testing coverage among pregnant women. And also, according to our national guidelines, we test those pregnant and breastfeeding women that are HIV negative every 3 months. So option A and B are actually the true reflection of what is happening. But in terms of the answer, the one which is wrong is C. So so C is the correct option according to the STEM question.
Thank you very much, Dr. Phiri. So we are going to conclude here. I just want to thank all the presenters and all the experts that were able to make it for this session. And also I would like to thank the network for your great participation during this session. So the registration link is still in the chat box. Please do register. It is very important for the program and also for your CPD points and CME points as well. So I think we are going to leave the session on for a little bit for those that didn't register so that they can just do that. Otherwise, thank you so much to everyone and we'll see you next time. Have a great day.
Thank you.